Over 130 women a day are being diagnosed with breast cancer in the UK. This constitutes for 30% of all cancers being diagnosed annually. Now, reconstructive surgery plays an important part in the cosmetic industry. However, there are a number of media scare stories, so today I'm at the Anglia Ruskin University with a number of industry leading experts to help me debunk some of these issues. I have here with me Professor Fran, Antonia Mariconda and Patrick O'Leary. Now, if we open up the conversation with you, Professor Fran, there's so many different types of breast implants available, but why have only a small percentage of women actually heard of polyurethane implants?
Well, there's a number of reasons. I think it sort of historically goes back to the development of implants, and as you go through the decades, I think you'll find that polyurethane implants have been around for nearly 50 years now. And when they were being developed for a specific reason, and I, as a simple surgeon, understand it was to try and get the implant to stay still in one place, to not move around, and then to try and reduce what we call capsular contracture, which is a hardening that develops over time on a lot of implants. And as you go through the decades, there's been times when they've been popular and the times when it all went quiet. And in Europe, particularly in Britain, it wasn't until 2006, I believe, that they were reintroduced. And that was mainly because it went through the CE marking system, which meant that if it was available in one country, for example Germany, it would become available anywhere within Europe, and hence it was invited back into Britain. And at that time, we had a population of surgeons that really didn't know anything about them, because from 1992, when they were voluntarily withdrawn from the market, the surgeons that were living with implants in those days were very much indoctrinated into what we call anatomically shaped implants made of a texturing which was supposed to reduce capsular contracture, or an implant that was never designed to stick in the body, was designed to be mobile in the body. And we were accepting results which, quite honestly, were never declared. We never, as a surgical group, presented and published our figures on longer than on any figures, certainly not at 10 or 15 years.
So what are the key characteristics around polyurethane implants? I mean, I'll open this up to you as well, Patrick, but I mean, capsular contraction is obviously a problem, but do these implants obviously overcome this issue?
Well, they don't totally overcome it, but they very much reduce the chance of it happening, and there's lots of hypotheses and basically a lot of surgeons will actually make their own opinion as to why it reduces capsular contracture. Yep. And I have an opinion as well, like everybody else. Yep. But basically, when you have a foreign body in the human body, there is a natural tissue response, which is you either try and expel it or you try and keep it. If you try and keep it, you lock it off to prevent it going anywhere. And the way the body responds is to produce these fibroblasts, which then produce collagen, which is arranged in a circular fashion, and anything that's circular, which we know has the ability to contract and shorten, will contract down, and the implants then will fold and they will buckle, and as they fold and they buckle, they then rupture, and as they rupture, they then leak. And the types of silicone that we use now, we like to think will stay where they're ruptured, but in the olden days, meaning in the 80s, that silicone would migrate quite freely to lymph nodes, glands, and around the body. But things nowadays are far, far safer. Okay.
Patrick, I mean, what's your view on this in terms of, the key characteristics you see from, obviously, these types of implants?
The key characteristic is basically, with the polyurethane, it was designed to reduce capsular contracture. The original implants were a smooth implant, they had problems with that having a large percentage of them having capsular contractures. They looked for alternative textures to put on there, of which polyurethane was one that they looked at, and the capsular contracture reduced. It came out actually long before what's now called the textured implants, which were done to mimic polyurethane.
So why are these types of implants particularly important for women that do have breast cancer that need reconstructive surgery? Why are polyurethane implants particularly good for these types of patients?
You've got to look through history, and you've got to understand what we were all trying to achieve. When I was brought up in surgery in the 80s, a thing called immediate reconstruction after mastectomy was not basically there. The principle was that if you remove a lady's breast for cancer, you had to get the wound healed, and you had to make sure there's no recurrence, before you then did a reconstruction. And the reconstruction, the options were putting some sort of implant in there or an expander to try and blow everything up. Generally speaking, that would thin the tissues and it would never give a great result because you're looking at trying to expand something into a new space which was very, very thin. Or you introduce tissues from the back to the front or from the belly to the chest, and then you use that as padding to have some sort of implant. And then along came so-called free flaps and tissue transfer from the tummy up to the chest, and you can get some really, really nice results. But the trouble with that is the surgery can take anything from about 5 or 6 hours up to 12 or 15 hours, and there's a pretty high complication rate when you bear out that you can actually do something really easily. Now the trouble with the implants that we did have was they had a high complication rate. You know, you're talking about a very high number of women, for example, that would have radiotherapy, and if you had a radiotherapy and an implant, they would go hard. And hardening is a cause of morbidity. It's painful, it doesn't feel right, it doesn't look right. So until the polyurethanes were understood, their activity, the way they react within the human tissue, this contracture I was talking about, the collagen isn't in a circular fashion, it's actually arranged in a 3-dimensional, if not probably 5-dimensional form, of which apparently all the forces of contraction all balance out. So we're talking about a rate of less than 1% of women will go hard over 15 years. And then it becomes totally cost effective for the NHS to forget about all these free flaps, to literally at the time of mastectomy tuck an implant in because we now know it's safe, and if we don't get a good result you can still have your free flap. But by and large in today's austerity, it actually should be a cost-effective way of dealing with breast cancer reconstruction.
So Antonia, you deal a lot with women as a cosmetic coach.
Yes.
When women have these types of implants fitted, how different do they feel after they've been placed?
Well, this is the issue, Stephen. I mean, I speak to lots of women who have breast surgery for all types of reasons. And there are very, very few women that I actually speak to that have polyurethane implants. Now, from my own research and my own reading, I've read some fantastic information and research about them and feel because of that, more women should be having them, especially women who have experienced complications with conventional cosmetic surgery. Again, as Professor Frame was saying, we have lots of issues with capsular contraction. And I feel from evidence-based research that polyurethane implants really do home in on that particular problem.
But in terms of the touch and feel, like once, you know, does this type of implant feel different to a conventional sort of implant?
Well, I'm sure Professor Frame and Patrick could tell you, based on their research as well, that it's very subjective to the patient. Obviously, they look and feel pretty much like an implant would in comparison to others. You might have the odd individual who says, well, they feel hard or they feel different. It is very subjective, but generally I've not heard that this particular type of implant feels any more or less different to another standard or typical implant.
Yeah, I mean, it seems like there's a lot of advantages using polyurethane implants, but why isn't more sort of cancer charities or patient support groups promoting this a lot more? Because it seems to me that everyone should be promoting these are the implants, because obviously we want the best for patients. I mean, what's your viewpoint on this, guys?
I look after lots of support groups and am part of lots of support groups for a wide range of breast surgery again. I think the problem with people not being aware of polyurethane implants is, again, it's consumer awareness. I think if more people were aware of the benefits of polyurethane in respect of other conventional implants, again, you know, they would be highly favoured. So we have I think we have a responsibility as breast manufacturers to increase consumer awareness. And I think if people are aware of the choices that are on the market, people would probably be more propense to ask for their breast implants by brand, which they should be doing.
Now this leads me on to the next question. I mean, Professor Frame, in your clinic you see a number of patients, and you know, I presume it's very important to give them the options. You know, you hear of these stories where patients aren't completely informed and are not given the options. I mean, do you go through what sort of implants that you will be inserting into the patients?
Yeah, I think in today's litigious society, you've actually got to show everybody that's interested in having this type of work. That's the cosmetic augmentation as well. You've got to get them to understand the history, understand where we have been and where we actually are now, and then actually I think you've got to show them the complete variety of implants that are available, because each of them has advantages and disadvantages. And also, if we're talking about breast cancer and reconstruction, you know, it's very easy for me to sell somebody that moves a block of tissue from the tummy to the breast as saying, you will have a tummy tuck at the same time as you're having your breast augmentation. But what people fail to tell you, there's at least a 30% complication rate of having that type of tummy tuck moved up into your chest wall. And if I were a woman, I wouldn't particularly want that. And I also wouldn't want to have an operation that delayed healing, that delayed treatment for my cancer. And I wouldn't want an operation, by and large, that may still need an implant, even though you've gone through that 12 hours of quite risky surgery. So I cannot see any advantage in most cases of today's philosophy of how you manage or excise breast cancer. I can't see many reasons to actually move a block of tissue up when we know we've got a very perfectly adequate implant that should suffice to cover most women having mastectomy reconstruction. There are times when you need a flap, I understand that, and there may be times where it doesn't give quite a desired result, because part of it is related to the structural anatomy you start with, and the surgeon that does the mastectomy, how much he has to remove and how much he mutilates the tissues, what sort of space he leaves. But by and large, today's breast surgeon is actually a little bit more savvy with blood supply to skin flaps, making sure there's a thickness there. Where is the breast within that skin flap? You know, you could preserve tissue, you don't handle tissues badly. There's absolutely no reason why you can't put a polyurethane implant straight into that space and you're finished. And the cost implications are huge, because an implant will cost you £350 or something like that, whatever the equivalent is. You know, a free flap procedure is £15,000, I mean £20,000.
Yeah, I think, you know, Antonio, you deal a lot in the media, and it seems like today more than ever, you know, surgeons do need to explain, you know, what is actually going into patients' bodies, because in the past, I think it was very much the patient's trust with the surgeon to carry on.
Stephen. And you know, generally at the moment, it'd be quite interesting to tell you that one of the most frequently asked questions that I receive through email, through telephone, through consultation is, I'm considering having breast surgery. How do I know which implants are the right ones for me? And that's a huge question at the moment in the cosmetic surgery, you know, general breast surgery market. And how do I answer a question like that? It is so surgeon-led, the choice of implants. I mean, my campaign, my message to consumers and patients is, when you are at consultation with your plastic surgeon, your cosmetic surgeon, and breast implants are presented to you, ask why your surgeon has chosen those implants. Because it's interesting to know, is it a price-led choice? Is it a choice based on familiarity and experience? You know, there are many reasons why a surgeon will choose the implants that he or she chooses. And it's important that as a patient, you are part of that choice. So my information is always, do your research, speak to other patients. If there's a brand or a type of implant that you're hearing lots about, do your research, you know, do some good fact finding. And if your surgeon that you are consulting with should not have the implant that you've heard lots about, ask.
I mean,
why?
It leads me to the question of you know, the preparation and the aftercare, the recovery. I mean, what sort of advice would you guys give in terms of a patient that is looking for breast surgery, whether it's the reconstructive side or whether it's more cosmetic? You know, where can they go for good information and support in terms of breast implants and breast surgery?
That's a very good question, Stephen. I mean, reputation and recommendation is what matters in this industry, and that's important. I think, first of all, if you're considering any kind of surgery, particularly breast surgery, that you are to find a good surgeon, a surgeon that is experienced in the area of breast surgery, and an experienced breast reconstructive surgeon. Obviously that would be an advantage. And once you're in consultation with that surgeon, have a checklist of questions which include the risks and complications, the side effects of surgery, the recovery and healing times, and everything else associated. And importantly too, the breast implant that your surgeon has chosen. Be part of that choice. It is your body, and rightly so, you should be part of that choice.
Patrick, I want to go back to the actual polyurethane implant, and how is it actually manufactured compared to a conventional type of breast implant?
Okay. I think first of all we need to separate out the contents, the gel versus the shell, and most of the difference is in the shell of the implant. Basically, all implants are made as a smooth implant, and for a smooth implant, obviously you cure it and you stop there. For a slightly textured implant, what you do is you put one more coat of silicone on there, then you put some type of dissolvable crystal, be it sugar, salt, something like that on top, and then cure that, and then when you wash the salt off, it ends up with a mottled surface. For a harder surface, then on top of that crystal, you put another layer of silicone, and then you scrub it, or somehow get the crystal out, which leaves a large pore for tissue to grow into. So that's where you can get different textured implants. With the polyurethane implant, you basically start with a smooth implant, you put a layer of silicone on the outside, and then you put polyurethane around the surface and cure it. So the polyurethane is cured into the shell of the silicone.
So in terms of the durability of the implants, I mean, how often does a woman need to get the implants changed? Is it longer with polyurethane implants, or is it quite consistent?
That's the big question.
Yeah, right.
You can ask that of any of the
Professor
implants
Fran?
data.
There's a number of little issues here. I was just taking up the way these things are made. I've actually had the privilege of seeing how they're made, and it's all done by hand. It's absolutely amazing. The testing is very, very thorough. But we do understand some of the physics about what happens with that gel. You can actually fracture it if your surgery is pretty incompetent and you're pretty heavy-handed. You can actually damage the way the implant is going to sit within the pocket. So I would emphasise the surgeon needs to have experience with polyurethane implants. You can't just use this and expect to get a great result. And to some extent that may be part of what's been going on, and that surgeons that get bad results give it a bad name. But for those of us that have used a lot of these implants, we know if you treat them in a certain way, they will behave well actually in the patient. Now, with regards longevity, we have to really look to two bits of data. One is the FDA report for 2011, which one would argue, I argue, isn't particularly a great report. It's looking at 8-year and 10-year data with two American products, not made in America, but sold throughout America. That's the McGann and the Mentor implants, and their results are pretty, I would say, poor, in that the hardening rate of one of them is nearer 20%, it's 19.1%, and the other at 8 years is getting up to there, it's about 12.7 or something percent. So going hard is going to be in 1 in 5 odd patients, probably within 8 to 10 years. And that going hard then becomes symptomatic, then you're looking for change. And what you would be doing if you changed for one of those implants again, you'd be more or less doubling the chance of it going hard. So that's what's been going wrong over the last 20 years. We've been looking at complications of implants which we now know are not the right things to be using. With the polyurethane implants, you're talking about 15-year data now, which is showing a hardening rate of less than 1% and a reoperation rate of less than 2% at 15 years. So it becomes a no-brainer. The polyurethane has something in there which is making it a better performing implant. Now, with regards to longevity beyond that, nobody has data on polyurethane implants. But surprisingly, I did pick up some data from Brazil a few months ago that 50% of the McGann Mentor implants have ruptured in a silent way at 15 years. So 1 in 2 of those implants will have a silent rupture, which is non-symptomatic, not causing any problems. You just pick it up and you operate and you find that they have actually ruptured.
So in terms of your own clinic, Professor Frame, do you only use polyurethane implants?
Since 2006, I started using polyurethane implants really because I was being told that they reduced the incidence of capsular contracture. That was what I was being led to believe, but I didn't really know the facts and the figures and why that is the case. And so I was giving it a very big challenge. I was taking implants out, very horrible capsules, stripping the capsules, putting polyurethanes in. I could immediately see that there was a better result. And then as you follow those cases through, they go a little bit firmer and then they go softer. And you don't necessarily need drains and that sort of thing, although people will say you do. So I was finding it very easy to understand really that the body does integrate differently to what it does with the other two implants that I had been using for the previous 20 odd years. So I then got the thought process, which is obvious now, but it wasn't then, that when I'm considering using them as the first choice of implant, as the second choice of implant, why wasn't I considering them as the first choice of implant? In those days, we didn't have the stats. We had a paper that was telling us it was good. In fact, there's 100 peer-reviewed papers, at least, that tell us it is a better implant than the others. And that you just take the plunge and you say, well, I'm now going to use it for primary breast surgery and revisional surgery and for reconstructive surgery. And so virtually everybody now, unless the patient specifically asks with the full choice of implant on the market, for another implant, I will nearly always use the polyurethane implants.
Well, I've got a couple of emails, and you know, anyone can start off the conversation here. One of them was from Carol, and she says, if I was to suffer breast cancer and require a mastectomy, is it always possible to then have a reconstructive procedure?
That's a technical question, Stephen. I think I'm going to leave it to the professor to answer that.
My surgical hat on now, it's all about, you know, how well the patient is. And what sort of age group and what the lifestyle is, because a significant number of women actually don't want a reconstruction, they want to be safe. And for those ladies, there's absolutely nothing wrong with having a mastectomy and having a prosthesis. They can manage with that until such time as they say they would like a reconstruction. And then electively, providing they're healthy, fit and well, they can undergo a reconstruction. Immediate reconstruction, one has to really seriously think about the benefit-risk analysis. You know, is it the right thing to do, for example, in somebody with a very advanced malignancy who needs therapy very, very quickly to get control of it? And probably the answer should be no. Let's just get it on board, let's get this patient safe, and then consider it. There is a very large number of women, though, if offered some form of reconstruction, will take it. There's a huge psychology, though, from a woman that walks in with two breasts to having one breast and a reconstruction. It is not the same. It's numb, you can't feel it. There's a shape difference, there's an edge difference, there's the feel difference. You cuddle your husband and the implant doesn't feel like a normal breast should. Now, that unfortunately is one of the facts of life. You're never going to, whichever way you reconstruct a breast, you'll never make a normally feeling, normally looking breast. There's always something about it which is never quite the same as the other side. But with the correct counselling and the correct discussions with that patient, by and large you talk them through those problems that can happen after mastectomy reconstruction. And generally speaking, providing you keep them on side, you know, you realise you're always working for them, then reconstruction is always possible.
Okay.
You know, within those parameters.
Just to move on to the next email, another one from Susan says, what are the telltale signs if there are any problems with an implant? What would you say?
There are a number of problems. I mean, basically the stuff we're talking about, a fairly benign thing, is this capsular contracture. Now, if something that contracts and goes hard and disfigures you makes you unhappy, then clearly that was the wrong option. But that still doesn't stop you having that implant taken out and the more advanced type of reconstruction, if you like, with tissue transfers going ahead. Tissue transfer is complex surgery. It needs to be in a specialist unit. It is available to lots and lots and lots of women, and lots of women are having it, and lots of women are incredibly happy with it. But you know, when you sort of see the inside of it all, you know, somebody has a long operation, and some units are putting in these flaps with 12 hours of surgery, with returns to theatre 10% of the time, with later complications of fat necrosis requiring extra work anyway, maybe 2 or 3 times. You look at the cost benefit of somebody that has a mastectomy, an implant, getting up and about straight away, getting home within a few days, getting about their life and getting back into life. And from the psychology point of view, there's a huge advantage to not having a knockdown period after major surgery.
I mean, just in terms of, you know...
That's a good question though, Stephen. I mean, that's a question that more organisations and charities and support groups for cancer victim survivors should be addressing. Because aren't these the organisations that are supposed to be supporting people who go through such experiences? So there should be more information on reconstructive surgery, and you know, lists of things to look out for should your surgery develop complications. So at first glance, you'll know if that's a problem and you need to speak to your surgeon or refer it to a medical professional. So, you know, I would emphasise that these organisations carry stronger information, both before, during and after the process.
Now, there's a few scary stories running through the media about breast implants causing cancer. Is this a myth or is this true? What's your comments on that?
It's basically a myth. There's absolutely never been any evidence to say that breast cancer is caused by breast implants. In fact, the opposite. There's one paper that suggests that actually breast cancer is reduced as an instance if you have breast augmentation. Do I believe that? No. Do I believe the statistic that says it doesn't cause cancer? No. I don't think the appropriate studies will ever be able to show one way or the other whether there are problems. There are all sorts of scares though with implants, and if I've got time, you don't mind, I'll just tell you a little bit about some of the issues. You see, when I was brought up, we had a very soft silicone gel, and that soft silicone gel you can actually see causes collapse. It feels great, or we used to think it was great, but in the human body it basically does that. It's not great. It's an implant that has no shape, no form, and by and large it'll do what it wants, which is usually does that and it leaks. And there were scares about that leaking. It causes capsular hardening, we know that, but also the scare was, did it cause an autoimmune condition similar to ME? And ME is ladies get tired, lethargic, miserable, and joint pains, arthritis. They get really unwell with that. And then it became pretty clear that there are diseases by association, not necessarily diseases by causation from these implants. In other words, women may well have got that ME-type symptoms without having implants directly. So when you start to look at women with implants and those without, the incidence of this ME was exactly the same. So therefore, when you're looking at women with implants without for cancer, probably the risks are exactly the same. You know, why should an implant that's not in the breast, it's behind, at least another layer behind the breast, why should that cause cancer in an organ that's living in front of it? You know, you're much more likely, if there's a problem with this implant, to have cancer somewhere else. And there's never been any documented evidence to say that women with implants are more likely to have cancer anywhere else. So the liquid silicone story, to me, started the whole, if you like, the philosophy about how safe silicones are. We all don't want that silicone around the body, so the implants started to harden up. And they started to, you know, we get different sizes and shapes and forms and texturing, which is what Patrick was telling us earlier. This is the salt-covered implant, and by salt extraction it leaves the texturing. And this implant is supposed to lock in the body. But you know it doesn't. The vast majority of the times it's allowed to float free. And what you actually get is a layer outside that, the space of which fills with a fluid. Now, we now know that, because of recent data, that 1 in 100,000 women get a late swelling. You talk about decades later, from being very good to suddenly getting a breast twice the size as the other. And that swelling contains a fluid. It could be blood, it could be a sort of transparent liquid, which is basically an exudate or transudate. Now that fluid itself is a bit of a problem. You probably would need to have the implant replaced and the capsule stripped. But of those women investigated, 1 in 100,000 of those could show, apparently, a thing called anaplastic large cell lymphoma. Now that's a type of immune tumour, if you like, that lives around the shell that has the implant in it, in the breast. Now the trouble is that actually occurs naturally without an implant as well. So the actual data is strongly supporting the fact that this didn't cause cancer. The cancer was there because you've got the implant there, we're able to pick it up. So disease by association is what we generally tend to think now as the issue. Now with polyurethane, we went from these sort of dome-shaped implants to what we call anatomically shaped implants, which were these. And this is an exaggerated example of a teardrop-shaped implant. And these implants often cause problems with regards the top shell bending over, or of rotation, or of twisting. And these implants, when they contract and they fold, they create great big ridges. And if you ever see these that are ruptured, they do create quite a solid jelly type of exudation, if you like, from the rupture of the shell. And it can be quite alarming, but actually that silicone, being cohesive, does tend to stay within the capsule which the body has formed. You do rarely see lymph nodes and glands coming up in the armpit, but it's not that common. Now, I've never seen anybody with lymph nodes, cancer lymph nodes, with silicone in, and that doesn't mean you haven't got breast cancer, but I've never actually seen the two together in one lymph node. And I've looked at lots of people with cancer and lymph nodes that have had implants. Now, if you look again at the polyurethanes, the polyurethanes have this rather furry sort of texture on the outside, and that is well adherent to an implant which underneath is fairly transparent, which is what Patrick was telling you earlier. This implant, they're more or less the same. The layers have been made, and on top of one of these goes the polyurethane. Now, this polyurethane degrades. It doesn't survive forever. It degrades over a period of time, and in my view, the maximum degradation is occurring within the first few years, and then it tails off. By about 10, 15 years, probably virtually all, if not all of that polyurethane is probably gone. Now, this polyurethane was made in a laboratory. It was made from two chemicals to make polyurethane, and then the body then takes that polyurethane and degrades it, but it's not into the two original products. It's made into something else, which actually the body, we don't know what it is. It's made into something which 80% of women will excrete in their urine. And of that product, in a laboratory, one can make another product from that product that's being excreting, which is what we call a thing called 2,4-TDA. Now this 2,4-TDA is the scare story about polyurethane implants, and it's been going around now for the best part of probably 20 years. And it keeps rearing its head, and it comes along whenever one is worried about things about breast implants. We all say that polyurethane is safe, but then we hark back to a thing that the MHRA put out in 2005 saying that this product called 2,4-TDA is released and it can cause cancer. Now, it has never, ever been reported as causing cancer in women, and it's been around for nearly 50 years, as I understand it, polyurethane, in South America and globally, and nobody has ever reported a case of cancer associated with this. The sort of cancer we'd be talking about, presumably, would be some sort of carcinoma of breast, and the incidence of that is 1 in 8 to 1 in 10 women. There's no increased risk of that just because you've got a polyurethane implant in there, having had breast augmentation. They've actually looked at the study in urine, the investigation. It's only obtained if you hydrolyse the specimen and you actually cleave off this product 2,4-TDA from what we call an oligomer. And that particular product is made by putting into 6 normal hydrochloric acid and boiling to more than 100 degrees. It's 107 degrees, I believe, the study originally that came out. So whatever you're doing, you're cleaving off part of the long chain molecule into a small molecule, which in the laboratory is 2,4-TDA, which apparently in the laboratory, in a certain form of strain of rat, will make some form of cancer in that rat. There has never, ever been a reported case of 2,4-TDA in women causing cancer. Now we've got to put that into perspective because, as I said, 80% of women that have got these implants in will excrete it in their urine over a period of 10 years, probably maximal the peak is in the first few years before it disappears. So there's also 13% of women who don't have polyurethane implants that actually have 2,4-TDA, which you can make from their urine. And the story there is probably around environmental polypropylene type products which we ingest. And that means we go to a food store and we buy something that's got polythene on it, we hydrolyse it, and we do know that you can actually ingest 2,4-TDA. If you've actually got it and made it, you've hydrolysed it, you drink it or you eat it, it goes straight into your bloodstream and into your urine and you pee it out. So 13% of women, and probably men, but it's never been done, probably have 2,4-TDA in their urine naturally from the environment. Has that ever been caused or incriminated as causing cancer? Not in my opinion. I don't believe I have any evidence for it at all. So one starts to feel that 2,4-TDA may be a bit of a problem, which we haven't really got the accurate data on. And I think it's a bit rich for the MHRA personally to come out and say it causes or could cause cancer, therefore don't use this implant, when we know in practical terms it has never caused cancer after 50 years of experience, 40 years to 50 years of experience, and therefore it needs pretty urgent review, clarification. Therefore the public is fully aware that the risks, if they are there, are less than 1 in a million of even having that product to cause cancer. So in my view, there's a lot of misinformation that needs to be made more accurately and corrected.
So Professor Frame, in summary, is there an estimated risk of cancer associated with breast implants?
There are published figures that show the estimated risk is less than 1 in a million which is probably below the radar of clinical significance.
So very, very low.
Yes.
I think, you know, we've covered a lot in this discussion, and I'm hoping our viewers have taken something away from this. I mean, what would be to sum some of these points up?
Can I add one other thing?
Yeah, of course you can.
There's always the other breast.
Right, okay.
And not only the screening and follow-up and everything else, but actually the other breast is never going to be the same. Whichever reconstruction you do, never going to be the same as the other side. And often you have to consider whether or not you need an uplift, a reduction. It's often an opportunity for the lady to get a better shape and form on the other breast. And symmetry is really what plastic surgeons are very well capable of getting. Often it involves putting an implant in the other side just to give us a bit of fullness. Now, which implant would you then choose? Bearing in mind there are complications from augmentation on somebody that's now got a breast that was normal, you're trying to make comparable with the other side. So again, it becomes, to me, a no-brainer. You've got to use an implant. Which is the best implant? Well, it's got to be a polyurethane. So if you've got a polyurethane on one side, well, why didn't you put one in the other side when you had the opportunity? It's something which isn't been made clear to the public, the ladies, the associations, and even surgeons. It's a very macho thing to move a flap. You know, as a surgeon, it's a lovely thing to do, but you've often got to think that is that the right thing to do in all cases? And I would argue the opposite. I would say it's actually not the right thing to consider as the primary option. It's something that has a place, but it's not the panacea. And I would, you know, as a member of my family, the first thing I would say, well, let's see an implant, see how you get on. If you don't like it, then we can go for the bigger surgery. Is
there any other final points that you two would like to make?
I would like to make the point and stress the point that if you are a patient for any kind of breast surgery, whatever the situation may be, that you, first of all, most importantly, find the right surgeon and invest a lot of time and effort into fact gathering and research gathering to make sure that you find the right expert. And the second thing is, be part of the choice for which implants are going to go into your body. If that means you doing your own research by internet, by reading, by consulting other patients who have been in a similar situation, do that. And finally, when you are in front of your surgeon and the choice of breast implant is being put in front of you, ask lots of questions. Again, ask why your surgeon favours the implant that he or she presents you with, and try and find out as much as you can. And my final piece of advice is watch the space for polyurethane implants. They really are making significant developments, and I think that what we've seen so far is very promising, and we should learn more.
Great. Patrick?
I just want to reiterate basically what she was saying, which that the women should become as informed as they can, and the final decision should be between, there's a lot of implants out in the market, but the final decision should be between the physician and the woman, bearing in mind that the woman pays the price for this. It's her body. She has the implant, so she should become as informed as she can.
Great. I'd like to thank you all very much for discussing this, and I'm sure the viewers have got some fantastic, invaluable information.
Thank you.
Thank you.